Hello friends, this is a case of mini gastric bypass. Here we will show you a skin to skin entire surgery. This is GP sternum. This is the costal margin, right and left. This is umbilicus. So this is GP sternum. We are going to perform this surgery by ipsilateral port position. So this is the GE junction. Here the GP sternum. So basically this is the GE junction anatomical landmark. And we are going to put the camera approximately 10 centimeter below the costal margin. So this will be ipsilateral mini gastric bypass surgery. This is camera. Now just below and left to the GP sternum, we will put the our Nathanson lever retractor that is donated by R here. This is the right costal margin, and we will put our right hand port. This is at this way. This is left hand port, and it will be the right hand at the level of the camera, that is in the midline. So this is our port position. The assistant, if it is required, we will put the assistant port here. So this is port number 1, this is port number 2, this is port number 4. Camera will be here. This is camera port. So we will start the procedure, and the various needle will be introduced at this point. So this is the various needle. Now irrigation, suction and hanging drop test will be performed. And it is sucked in. Now insufflated tubing will be attached, and insufflation is started at the 1 liter per minute, and preset pressure is kept here 15. Now if you will palpate, homogeneous distension is started, and we can get the liver dullness get obliterated on the right hypochondrium area. You can palpate to check, because gas first goes there, and it will give you tympanic sound or sound like a ripe watermelon, and that will confirm that a smoothly gas is going inside. This patient has few previous surgeries also. You can see some scars are there in the abdomen, and the BMI is 48 in this patient. So we can see that liver dullness is started. Liver dullness get obliterated and tympanic sound will come. We will wait till the actual pressure reaches the preset pressure, and then other port will be introduced after introducing the telescope. So gradually you can see abdomen is distending, and now various needle is removed, and the first optical port will be introduced. This is 10 port. We will use a striker telescope and the 30-degree 10 telescope to perform surgery. Now the maximum flow rate will be increased to 10 liter per minute, and telescope is introduced. So we can see that there is adhesion or not in the previous scar, but luckily there was no much adhesion and everything was fine. Now the second port is for the Nathanson lever retractor, and this port will be the left hand of the surgeon. So we will put first the left hand port and take a grasper just to do the some diagnostic. A 1A traumatic grasper has been introduced and it was fine, everything diagnostic was done, and then the epigastric port is introduced just left to the GP sternum. Port was taken out and Nathanson lever retractor will go percutaneously. And now Nathanson is going to be clamped with a stand, and that stand is attached with the OT table. So it is fixed now and it is retracting the left lobe of the liver. Now this will be the right hand port. Right now it is 5 mm, later we have to increase it to 12 mm for the stapler. So now we start the surgery. We can see the Nathanson lever retractor is lifting the liver. Left lobe of the liver, as you can see, this is a fatty liver. Of course, you will have a lot of load of momentum in the bariatric patient. It will be like that. This is the lesser curvature, this is the greater curvature. If you will pull the momentum down, you can look at the spleen there on the top. That is a spleen on the top visible. And you can watch the first and second gastric pedicle. And approximately 10 centimeter below the GE junction, you have to make a retrogastric. Actually, it should be 12 to 16, anywhere you can make. Bigger is the tube, gastric tube, it is better. And that will prevent the biliary reflux. So here retrogastric tunnel has to be formed at the lesser curvature. Mini gastric bypass is a straightforward and simple surgery, and it is a realistic procedure because 80% of the excess weight will be lost at the end of 1 year. And unlike sleeve, it works even for carbohydrate eater and grazers. So, father of this surgery was Professor Rutledge. Unfortunately, he expired in the March this year. Professor Rutledge was very known to me. He was also a faculty of the World Laparoscopy Hospital, and he was regularly taking classes here online also. And he was also telling that always that India is his second home. He has presented his new surgery mini gastric bypass MGB2 at our WALS conference, which was conducted by us in the February this year. So unfortunately he is not with us now, but his surgery will always be there. So we can see here this retrogastric tunnel is almost formed, and after getting this you will be able to see the posterior wall of stomach. retrogastric cushion and omental bursa will also be visible. So we can see the posterior wall of the stomach. Luckily, this patient has no much adhesion in the posterior wall, and that is good thing, because many patients who has gastritis, they have a lot of adhesion. So now this is a stapler, and this is horizontal row of division, and that will be 45 mm. You can fire 3 times, and then you can pull the stapler handle, and this is the horizontal row of division is done. Little oozing is there, but that is fine, it will stop itself. You should not use any energy to stop it. And then you can check again the posterior wall, and this is okay. Now you can use the start taking the vertical row of division, and you have to go up to the GE junction. In mini gastric bypass, there is no much leak chances at the level of the GE junction, because it is a low pressure, unlikely to sleeve gastrectomy. You can use all purple color cartridge or blue color. So this is the first vertical row of division, and we have to go all the way to take this gastric tube. The length must be 12 centimeter or little more, because you should not make a teeny pouch, unlike RYGB where we make a very teeny pouch. That's why this surgery is also called one anastomosis gastric bypass, that is OAGB, or you can say loop gastrojejunostomy also. So this is first row of the vertical row was taken, and after that we will check again posterior adhesion, and luckily no adhesion. Now we will put a gastric calibration tube. This is the 36 French gastric calibration tube, which is introduced by anesthetist, and that will come in this gastric tube, so that further stapling line will be straight, and you can make it 36 French. So this is the second cartridge, and the bougie is already in the place. That's why you can see left side, this circular bulge is due to the gastric bougie, that is gastric calibration tube. As we know, the length of our cartridge here is 60 mm. So in vertical row of division, 2 or 3 cartridge, 3 average is required, which you have to fire. You can use either Aslon Flex 60, or you can use Tri Stapler by the Covidian, or Panther, or Lotus. There are many Indian companies also. Now they have come with a very good and economical stapler. Now this is the third cartridge. Before firing, you should wait for couple of minutes so that fluid will displace. Here we think that there is a small portion is still uncut, so we will use fourth one also. You should not apply any clip or any knot, and don't try to save the number of cartridges, because leak chances will be more if you will try to do some other technique of knotting or clipping on the remaining part of a stomach. And now we can see that entire stomach, a new gastric tube is formed. You may say it is a new esophagus. So it's over. And now stomach is, remaining stomach is detached and nothing is attached. This is omentum, that is fine. So it's good. Now you should inspect your little bit, bougie should be little bit pulled, not completely, and lift the gastric tube and check that there is no any bleeding. If there is any oozing, we can do suction and just try to remove the blood which might have collected into the subdiaphragmatic area. And a staple line will be examined. So this is the our gastric tube. I will not say pouch because it is basically a tube. Unlike RYGV where we make a teeny pouch, we can see the bougie here. We will perforate the posterior wall because here we will do the side to side anastomosis with the jejunum with the posterior wall of the stomach. So little bit fat is there, that can be separated. So let us now go to the ligamentum trees and start calculating the jejunum. So all the omentum has to be pulled up and we should try to find out the first part of jejunum. This is little time taking job because you will have a lot of overload omentum, and generally MGB is done anticolic. You don't have to go retrocolic, just like traditionally in the old time gastrojejunostomy was performed retrocolic, but MGB by laparoscopy is done anticolic. So this is, we can see, if you will pull the jejunum, then it will not get further pulled. That means this is first part. And then you have to calculate 2 meter of the bowel lobe. So this is 10 centimeter. Every time 10 centimeter you can calculate, or you may calculate 5 centimeter or 4 centimeter 50 times. That is up to you. So here we are calculating 10 centimeter every time. So this is 1, this is 2, here it is 3. 2 atraumatic bowel grasper should be taken. This is 4. You should not use normal grasper to walk over to the bowel. This is 5. This is 6. 7. 8. Right side to us is the BP limb, biliopancreatic limb, or you can see afferent limb, and the left side is efferent limb. So you have to keep on, because we are taking 10 centimeter each time. So you have to walk 20 times. These are bowel grasper. These are completely atraumatic. Take care that torsion should not happen. And when you calculate, trauma to the serosa should not happen. You should try to hold with the grasper handsome amount of the bowel. If you will apply hold it very a small amount of bowel, then trauma will be more. So we are using here 2-meter bypass, minimum 1.5 meter, and some surgeons they go up to 2.5 meter also. It depends upon how fast you want the weight to reduce and comorbidity to go away. Mini gastric bypass is also a very useful procedure for the type 2 diabetes, especially MGB2. So now this calculation is over. After that, you will perforate the antimesenteric end of the bowel and take care that only serosa should not get punctured. You should go complete full thickness, and you should be able to enter into the lumen without damaging the opposite margin. Harmonic is good instrument. You may use hook, but harmonic has a advantage that it doesn't create much collateral damage. So it is now punctured. The graspers and the entire tip should be introduced to make it sure that mucosa also should be punctured. Bile should be visible. After that, we will take again a stapler, endo-GI, and then one of the jaw of the cartridge will be introduced into the jejunum and another in the stomach. Here this is perforated the posterior wall. It is not necessary that always you puncture the posterior wall. Anterior wall also can be taken, whatever is convenient, and you should take care there should not be torsion. And now you will do the anastomosis. How big this anastomosis should be there? It varies. Some author they take 45 mm anastomosis. Rutledge was taking complete 60 mm because he was saying that dumping syndrome is good because that way patient will not eat a ton of carbohydrate. You can fire 3 times and then you can pull it back the cartridge and side to side anastomosis will be complete. So you can see that mini gastric bypass is not a difficult surgery, and basically if you have the advanced stapler or advanced energy sources, then it can be performed very easily, and with the ipsilateral port it can perform much easily. So it's done. Now you can see the bougie in the stomach end, and posterior wall of anastomosis will be checked for any bleeding, and you will make it sure. Now here we are using barb suture for closure of this stapler line, the perforation of the stapler. So we can start in to out on the jejunal end and out to in the stomach end. And this will be two-layer suturing. We'll do continuously. Barb suture is practiced more nowadays for bowel anastomosis. So we can see this was in to out in the jejunum and out to in, it is going into the stomach. Barb suture has a loop there in the starting, so you don't need to have the knot. A starter is not required. So this is corner. First you should start with the corner. You can start from any side, from below up or above down, and we can see this loop is pulled and it will lock. Suturing should be good, and after closure of this you have to check that methylene blue, that there should not be any leak. So please see the entire suturing. At the end you will like it, because correct suturing is required for any laparoscopic surgery. That's why it's called that there is no future without suture. This is the full thickness bite taken, not only seromuscular, completely in to out and out to in. You can use the suture as a retractor to lift it. Some of the surgeon, they close this by the another stapler cartridge by endo GI. They put bougie in the efferent limb, lift the perforated area and fire one more stapler to close the opening. But generally suturing is better, because why to waste the money in that? And sometime when you are firing it, the first staple line, horizontal staple line, will give you very less tissue to do the closure. So that's why suturing should be better. Vicryl also can be used. You can use 2-0 Vicryl to do the anastomosis. Generally, in laparoscopy, we are taking one number thicker suture compared to open surgery because there is a lot of insult of the suture with our Maryland and needle holder. So you should try to handle the suture gently. Now we have reached to the other corner in the angles. And this is little bit muffing of the first horizontal line of the stapler with the suture. In the jejunum, you take seromuscular. The stomach, you can take full thickness. Here, this is a vertical staple line, but just couple of bite you can take over the vertical staple line, so that in horizontal staple line, less pressure will be there. So it is terminated here. However, in the barb suture, termination is not required, but we should not believe. The company is saying it is unidirectional, you don't need to terminate, but better is to terminate. So this is the afferent limb, and here is the anastomosis, and this is efferent limb. Because already we have terminated it before, so that's why it was not necessary to terminate again. Now this is the second layer started, and this is again seromuscular. This is the posterior wall of the stomach. Because now we have cut the valve suture and there is no loop now, so you have to start with a knot. This is seromuscular again on the jejunum. This will reinforce the first layer. So this is looks good, and buoy also can be pushed to check that it is lumen is okay. So right side we can see this is BP limb, left side is efferent limb, and now you can ask your anesthetist to prepare for putting the methylene blue, and both the afferent and efferent limb has to be catched by atraumatic long jaw grasper, and methylene blue leak test will be performed. And you will see the distension without any blue color coming out. A staple line also will be checked this way. We can see it is distending, but we don't have any leak. So this is outside. We will show you. Here you see that through the bougie, this is the methylene blue which was introduced, and there is no leak. If leak is there, you must have to suture it. You can check on the upper line also, there is some oozing but no blue color. So it looks good, and anastomosis is complete. Now NG tube will be removed. This is the methylene blue you can see in the saline which was introduced. Not entirely, maximum 50 to 100 ml is enough to check. That will go through the, you should not take separately NG tube, through the bougie NG tube should go to distend it, and now it will be withdrawn. So gastric calibration tube has to be slowly withdrawn out. So it's fine, you can check the posterior wall, you can check all around. Suction has to be done. If some blood is collected in the splenic fossa or subdiaphragmatic area, any injury of the liver also must be checked. However, Nathanson generally doesn't injure the liver because tip is bent in downward direction. We can see it is red, no blue. This is the remaining stomach. We don't remove the stomach, that's why this is a spleen here, you can see on the left side. That's why MGB is reversible procedure also. In some of the patient who absolutely not tolerate due to any reason, you can reverse the procedure. How? By a stapler you can detach this loop, and again side to side anastomosis with the remaining stomach can be performed. Now we will cut the suture, and suture will be taken out. This is your loop which was termination. That also you can cut the loop part because it is having some spike there. that can trap the bowel or omentum. This is the problem of the barb suture, because sometimes adhesion happens if the tip is long. So it's almost over, and now we will check final inspection and telescope will be taken out. So thank you very much for watching this video. Have a nice day.